Hello, my name is Louren Flaherty, and I am a doctoral candidate at the University of Louisville in my home state, Kentucky. And I'm very happy to be here with everyone this morning. So we're going to just dive right in. The talk that I'm going to give will be referencing a recent publication entitled Clinician Word Use in Dementia Evaluation Reports as a Function of Cognitive Impairment. And yes, that is a mouthful, but hopefully by the end of it, it'll be perfectly clear. So before I dive into the study itself, I want to give some background because the study was very exploratory. It was open and it was very unique in the way that we approached it. So some background. I do a lot of work with cognitive impairment. Um, I just matched for my internship, and that's the direction that I'm wanting to go in with regards to neuropsych. And so cognitive impairment is something that we see a lot. So at this time, obviously, cognitive impairment is rigorously studied, and rightfully so. I'm sure everybody here is aware of the demographics that we see now with those with cognitive impairment, but also what we expect to see in the future as well. So it is being studied, and rightfully so. But there's more to cognitive impairment than just the etiology, the numbers, the treatment, and the testing procedures. There's a whole different side of it, and that's the side that gets less attention, right? Because it has to do with the experience of impairment, which has to come from the family or the patient themselves or even caretakers. And the experience itself is pretty subjective, right? So even less than that, even less attention and research is given to the way that clinicians, the way that we conceptualize the impairment in others. And that's very interesting, right? We are kind of in there as an instrument, as a tool, a diagnostic tool, and we have to incorporate all these data to come up with a report that conceptualizes it. But aside from that, there's not much research given to how we conceptualize it to our own selves, what we actually feel and think and say about it. So those with cognitive impairment, they obviously have a lot to deal with. At the forefront, though, from a bioethics point of view, I have a master's in bioethics, and autonomy and personhood are absolutely at the forefront of this particular condition, for understandable reasons. So we're going to talk a little bit about personhood, and I'm just going to go ahead and define that so that we can understand basically what we're talking about here. So personhood, as defined by Kitwood, is a standing or status bestowed upon one human being by others in the context of relationship and social being. So it's basically how not only do we see ourselves, but in relation to what others have told us we are. And that exists in a whole different system of networks around us. So it's very contextual. But it has to do a lot with how we define ourselves as a person. So personhood. So Kitwood goes on to talk about personhood and about the fact that language itself shapes relationships. I mean, language is a reflection of how we think, and we use it to communicate how we think, how we feel, opinions, needs, wants, everything to others. So obviously it's going to shape relationships with ourselves and others, right? But that does not exclude clinical relationships. That's the same for clinical relationships. So then Kitwood goes on to talk about, within personhood, something called the I-it relationship. And in this case, the clinician would be the I, the patient would be the it. It's obviously not favorable in the way that it's written. So it would be a detached, cool, instrumental, really safe space for the person that is the I. So for us, right, the clinician. And sometimes that could be at the expense of the it, the patient. They're obviously in clinical relationships, they're more vulnerable. And Kitwood talks mainly about clinical relationships. They're more vulnerable. They're coming to you for expertise and help. And we take it upon ourselves to, pretend like we're this very objective tool testing tool, and so that does kind of give us a risk-free space where we get to be detached. But the question is, are we really? So then there's the other relationship, I, thou. And that communicates social understanding, respect, and intimacy, and also each person's value in the relationship. And so that helps the person that's more vulnerable, involved, and intimate, but it also preserves the personhood, both, but primarily the person living with dementia or other forms of cognitive impairment. So specifically talking about clinical relationships, I would venture to say that the way that we envision the perfect clinical relationship has probably changed over the last several decades, whereas we used to sort of really idolize this idea of being purely objective, no feelings, all of that, because we thought that it gave us a better understanding of what was going on if we weren't involved emotionally. I think we're starting to realize, along with many other changes in healthcare, I think we're starting to realize, though, that there's no such thing as true objectivity, because you cannot have a view from nowhere. And so, and also that there might be something therapeutic about having a professional relationship that still preserves the personhood of both people. So in a review regarding clinician language, which has a lot to do with relationships, because we just talked about how language defines relationships. During feedback sessions after a cognitive evaluation, some clinicians insisted on using vague terms, and the point of this was to soften the blow. So they anticipated that the patient was going to have a hard time with it, and so ahead of that, they wanted to do something to soften that blow. Now, some insisted on using more precise language, such as the word dementia or maybe specifically Alzheimer's. And the reason, we don't know. It could be to remain purely objective. It could be to not take into account, not to allow any confusion. Some clinicians would decide how to describe the diagnosis and prognosis based on their predictions about the patient's reaction. So that just goes to show that even in clinical relationships, even if you really strive for that I-it relationship, there's still sometimes things about our languaging that can communicate maybe what we're really thinking or feeling about it, even if we're not sure. So labels. We all know that with mental health, there's definitely a lot of stigma with those labels. And that also comes with cognitive impairment as well, as long as, many other labels. So diagnostic labels and language use may affect whether people utilize the medical services they need to avoid the social impact that they carry. And it also suggests that those that have suspected cognitive impairment, they go to the lengths of avoiding diagnosis or research or treatment for fear of rejection. And so these efforts to escape rejection is an avoidance to feel that otherness that really relates back to that I-it relationship we were talking about as it pertains to personhood. It obviously, to the extent that it would make people avoid getting the treatment they need, it obviously that social impact is strong enough to keep them from doing that, even if they think they need that. So tying it all together, cognitive impairment, personhood, clinical relationships, and language, our use of language as clinicians is often, and people, is often a representation of our thought patterns, right? With clinicians being no exception, even if we're trying to be purely objective. This holding true, clinician thoughts and emotions might influence the wording of the evaluation report. And so this goes back to the I-it and relationship and how it could create feelings of otherness. And it could have a real impact on the people that we see, or even their caretakers, or even people that they talk to. So the purpose of this study specifically, we use something, I call it LIWC as an acronym, but it's Linguistic Inquiry Word Count. We use this to explore how clinicians use emotion, cognitive, and various analytic word groups when writing evaluation reports of people that were diagnosed with dementia, mild cognitive impairment, or no cognitive impairment, or at least no evidence of cognitive impairment on testing. So obviously, before they wrote the reports, they already knew the criteria that that particular patient met. They already knew what they were going to diagnose them with. So this study seeks to answer whether cognitive impairment itself, the group, whether it's mild cognitive impairment, dementia, or no cognitive impairment, if that influences the way clinicians use words, particularly emotion, cognitive, or analytic word groups. We're looking to see and through a very associative logic, the extent to which clinicians are prone to emotional reactions just like everyone else when working with people living with suspected dementia. And we want to see if it's reflected in their report writing. So the objective of this study was, again, to examine the extent to which levels of cognitive status influence patterns of word use in these evaluation reports. So what we did is we utilized neuropsychological evaluation reports. We took reports that were already written from 61 geriatric primary care patients. So they went to go see a primary care physician, and there had maybe some suspected dementia on behalf of the physician, or maybe a family member, or maybe even the person themselves went in there and they're saying, I just can't remember things the way I used to. And so they were referred to a clinic, a testing clinic. So we pulled 61 of those reports that were already written, and we ran them through the Luke computer system or software. And so Luke software is pretty interesting if you look up other research that's been done with it. It's basically, it is a software that goes through every word in a particular document and assigns it to different groups. And so it could be anything from like pronouns, past tense, future tense, like paying attention to what tense people are using. Do they use more angry words, sad words, motivated words, all kinds. There's tons of word groups. And they report when they go ahead and assign each word to a word group. Sometimes a word can fit into more than one word group. But it spits out these figures of how much of the entire document, it spits out a ratio, basically. So out of the entire document, if there's 0.12, that is a ratio of that particular word group as it pertains to the entire document. It's pretty interesting. There's a good amount of research in there, and it took forever for them to assign these particular words to different groups. There's an entire dictionary that's been revised over and over and over and over again. So I definitely suggest looking that up, not just with psychology or neuropsychology, but also just looking at many other things that it's been used for outside of this field. So anyway, so we use that software and to examine clinician language use in those patient reports. We ended up using ANOVA analyses. Obviously, the three groups that we were looking at were the diagnostic groups, no impairment or no evidence for impairment, MCI, or dementia. Now, I realize that these are outdated terms right now. The DSM-5 has termed them differently, but we still, the primary bulk of research at this point that we refer to was still based off of the criteria when they were calling it MCI and dementia. So, but they are interchangeable, same thing. So anyway, yes, so we used ANOVA analyses to look at that, trying to see if we could find anything significant about at some of these example words. So we have anxiety, nervous, afraid, tense, anger, and these are just examples. The dictionary is humongous. So causation, because, effect, hence, certainty, always, never, negation, no, not, never, time orientation. So end, until, and year. This wasn't entered into the future-focused words were not entered into the abstract, but they were definitely tested for. In the entire document, there was something to be found there. And when we look specifically at the background and conclusion section, it was not significant. But future focus, may, will, soon. So those are some, I guess, examples, and also a quick way of looking at all the ones that were significant, all the ones that were not significant amongst the different sections and the entire document. Oh, and these are word use means. So we go back to how Luke basically presents these words. This is or presents the amount of words used per the entire document, and this is just sort of a figure that would show, I guess, if you wanted a visualization of what words were most likely to be used just by looking at it. And it also tells you what section that they existed in as well. So yeah, and then the conclusion, obviously, the differences in clinician language use across different diagnostic groups may be reflections of implicit emotional reactions. And the ultimate conclusion is there were differences in clinician language use across diagnostic groups. And so maybe they're reflections. Many of these patterns found in the study can also be linked to previous research concerning word use and underlying thought processes. So if you go back and you look at Pennebaker or things like that, or publications, then you can look at all the different ways that Luke was really standardized and the dictionary was made. There's a lot of research there that you can look at about really kind of exacting meaning and underlying thought processes or emotional processes from word use. So, and many of that existing research was definitely linked to the patterns that we found in the study as well. So overall, awareness of language use is helpful in clinical relationships. It can help maybe to attenuate stigma and really facilitate treatment and research. Thank you, and I hope you enjoyed.